My name is Dr. Dhiraj Ail, and I work at the Darren Hospital in the United Kingdom. That's my hospital. It's supposed to be one of the first PFIs which was set up in the country. It's a 400-bedded hospital, and we do our shares of trauma there. I am the lead for fracture neck of femur, and that's the reason why I think this topic is quite dear to me. I'd like to thank the faculty here at KEM as well as Anita Madam for giving me the opportunity of presenting my work here today. So thank you very much. So why are we discussing this topic? Why is this topic so dear to me? Mortality in fracture neck of femurs is very high. So if you look at the 30-day mortality, it's around 8 to 10% worldwide. And the yearly mortality, only 22 to 24% of the patients are alive after having this episode at 1 year. So you can see that it's a procedure which is associated with very high mortality. If you look at CABG, the mortality is anywhere like 2%. For colorectal surgery, it could be anywhere from 8 to 25%. So this occurs. So this kind of patients present with a very high mortality risk. It's also shown that adherence to pathways improves outcomes in these patients. And hence, if you have an enhanced recovery protocol or anything of that sort, that will help you improve the care of your patient in these kind of scenarios. The third thing is that our primary aim is to improve safety, patient care, and satisfaction. So what are the risk factors in elderly surgical patients? If we actually look at what we as anesthetists dread to anesthetize, I think some of the most common things you'll see is, someone with an uncontrolled atrial fibrillation, patient in heart failure, patients having respiratory problems, severe COPD. And these kind of patients will present you with more than one challenge. Any patient of fracture neck of femur will have at least one of these conditions, perhaps more. We can know that most of these patients are elderly and they have an age-related decrease in their physiological reserves. Increasing number of comorbidities present as your age advances. Cognitive impairment and sensory impairment. We've seen a lot of these patients now having neurocognitive disorders like delirium, they have dementia, Alzheimer's, and they present and they can be very, very challenging to take care of. Most of the elderly patients are frail and have a reduced functional status. That itself provides another great challenge for us. Polypharmacy, any patient, especially in the UK, when we see, have at least, 10 medications written up, and out of any given prescription, you will see some drug interactions. So polypharmacy is very common, and many of these drugs can have interactions with the medications which we use. And of course, many of these patients have reduced albumin, which has the implications for pharmacodynamics in patients, as well as many of them are malnourished. Now, our patient expectation has been increasing, year over year. We are what we're knowing as aging much more gracefully. We're living longer, we are aging better, and we're leading a more active lifestyle. Now, this is something I wanted to show you. This is a graph from a study which has been done by Medin et al. This was published in Health Economics in 2015. The only reason of producing this chart is to see whether what is the mortality of fracture neck of femurs among European countries. Now, if you look at here, this is the 30-day fatality rate in most of the patients. So most of the patients in Europe will survive, as I said, to around 8 to 10%. Okay? Hungary is the only country which has got a much higher mortality rate, and that was what was reflected in this study. This, again, shows the 1-year mortality rate. And if you actually look at the 1-year mortality rate, you see Hungary, again, appears to be somewhere around 35% there. Whereas across the board in Europe, you'll find that most of the mortality rate at 1 year for fracture neck of femurs is anywhere between 20 to 30%. That's an average, as we said, of around 22 to 24%. But the length of stay here, if you look at it, the length of stay in Italy probably, is here. This is Italy. It is the highest, and the mortality rate is low. But at the same time, you can see that there are variable length of stays which do not translate into an improved about mortality. This could be very similar to what we have in a developed country like India, where our resources are very, very limited. We are, not every area in India can cater the same way for fracture neck femurs, and not everyone can keep the patients in for the duration, like in some places, which is up to 15 days or more. And hence, the mortality might be higher. I really don't have the current figures of what the mortality rate in India is, but I think throughout the world, the average is around 20 to 25% at the end of 1 year. So, perioperative period, I think one of the most important things, I think, is an orthogeriatrician or a POPS review, pre-optimization of these patients, risk assessment, minimal fasting from surgery, and avoiding benzodiazepines and anticholinergic drugs, because these are the drugs which are associated with the maximum amount of incidence of postoperative cognitive dysfunction. And this is something else which we encourage people to do in the UK. We fill in what's called as a treatment escalation plan, because even before we operate on these patients, we decide whether this patient would be a candidate for intensive care or a high dependency area, as well as ask the patients if they have the capacity, whether they would want to be resuscitated or not to be resuscitated. Again, I assume this is slightly different on the resuscitation laws, which is there in India as compared to the UK. Now, orthogeriatric or the orthogeriatrician review is, I think, one of the most important things which we follow. Most of our hospitals have an orthogeriatric board, and orthogeriatrician is always involved with the care of the patient. Now, why do we need an orthogeriatrician? I think one of the most important things to understand about fracture neck femurs is these are medical patients who require surgical intervention. Throughout these years, we've been looking at them as surgical patients, and if something goes wrong, we send a medical referral so that the medics come and treat. I think it's time we change our thinking, and we have to acknowledge the fact that most of the fracture neck femurs have that because they have fallen down due to a medical reason. It could be either an infection, it could be an arrhythmia, or it could be someone having a much more serious disease. So, what does our orthogeriatrician or POPS review help with? It helps with changing medications when there are interactions, recognition of undiagnosed pathology like cognitive problems, social work referral, much better communication with family and carers, and I think they can institute much better measures to prevent delirium, because they are much better than us at diagnosing delirium, and better discharge planning in these cases. Frailty. I think frailty, it's been increasingly recognized now as an independent predictor of predicting post-surgical outcomes. Frail patients are known to have poor patient outcomes. This was a study where there was a total of more than 200,000 patients, and out of these 100,000 patients were orthopedic patients, and they found that frailty was an independent predictor of poor surgical outcomes and readmission. So, pre-optimization. How do we pre-optimize these patients? One of the most important things is correction of anemia. Now, what is the magic number? I think there have been multiple studies after the TRIC trial has come. Now, I think the TRIC 3 trial was presented recently, where they used a trigger of 7.5. And I think they again came up with the same conclusion that it was a non-inferiority study. Neither should benefit. But if I have a patient who at 7.5 is not behaving very differently than an HB of 9.5, then there is no point of me giving blood, because I know blood is associated with complications and there can be multiple problems occurring because of blood transfusion. So the other thing which has come is now in elective surgery in the UK, the NICE has issued clear guidelines on how and when do we supplement with IV iron and oral iron. And I think going forward, I don't think so we can use IV iron to correct anemia in the preoperative period, because we do not want to wait for long. But there might be a role of post-operative commencement of either IV or oral preparation of iron, and the use of a very restrictive transfusion trigger. Correction of electrolyte disturbances. Most of the times we find that the patients have got significant electrolyte disturbances. This could occur either due to nutritional reasons, or it could occur because most of these patients have kidney disturbances. Also, you find that most of these patients are on diuretics, and I think that is one of the most commonest reasons of hypernatremia or hyperkalemia, which is seen in this group of patients. All it requires sometimes is to just stop the medication and supplement some electrolytes, and these patients are good to go. Correction of coagulopathy and anticoagulants. Now, we are in the world of, I think a lot of different kind of anticoagulants. Years ago, it was just warfarin, and then we had antiplatelet drugs. Now we have the DOACs. Every day in the market, there's a new DOAC, and someone ends up with you having, all these new anticoagulants. And our basic problem is that most of the time, spinal anesthetic is the preferred anesthesia for these patients, and we just get worried about what to do with these anticoagulants. I'm going to have a slide on this ahead, so I'll talk about it at that time. Prompt recognition and treatment of sepsis, treatment of uncontrolled diabetes, as well as treatment of acute decompensated heart failure is very, very important in the treatment of these conditions. Trachea and bradyarrhythmias. Now, the most important thing I find in these patients is giving analgesia, preferably a fasciitis block. You could either use an ultrasound-guided fasciitis block, either a suprainguinal or an infrainguinal technique. You don't even need an ultrasound-guided block. This is one of the simplest block in the lower limb, where all you need to do is look for 2 pops and inject the local anesthetic. Avoid the use of opioids, because opioids are associated with delirium and a lot of other problems. If the patients are used to some drugs like alcohol, treat their withdrawal in the preoperative phase. Now, risk assessment, I think this is again one of the most important things while treating these patients. And the reason I say that is it's reflected by, why risk assessment is crucial for the elderly population can be just summed up by this study published by Atul Gawande. I mean, you must have heard his name, because Atul Gawande is a guy who's come up with the WHO checklist. He's a urological surgeon in America. And he did a fantastic study. And this study, it's amazing to know that when he did this study, 1,802,029 elderly patients underwent surgery. Okay, in this, 32% underwent a surgical procedure during the year before death. Or you can say that almost 600,000 people died in the first year after they had surgery. Okay, 18% underwent a surgical procedure in the last month of life, or around 325,000, that's 325,000 patients died within a month of having the surgery. And the worst, I think, is that 8% underwent a procedure in the last week of their life. Now, what is really sad is 145,000, that means 145,000 patients died within the last week of surgery. And hence it becomes very important for us to understand in the geriatric population whether it's really important to do the surgery. It's just not a surgeon asking us, do a surgery and go ahead and do it. But at the same time, the only thing which is different, which are fracture neck of femur patients, is that we know 22% of these patients will die in the first year. And in most of the times when we do these cases, we do this as a palliative procedure, because for a fracture, fixation of a fracture is the best analgesia. I mean, you can pump them up with opioids, give a local anesthetic talk, but for a fracture, the best treatment is actually fixation of the fracture, because that's what takes the pain away. And once you take the pain away in these patients, you can nurse them better. Now, how do we do the risk assessment? For the fracture neck of femurs, we have a very simple score, which is called as the Nottingham hip fracture score. I mean, it's available on a mobile phone. It's an app now. You just put all these numbers and you get a risk mortality prediction. My personal favorite, as I like using this calculator, it's called the riskcalculator.facts.org. It's a free online resource. It is from the American College of Surgeons. So if you look at it, it just gives you, simple things like age group, female, write the name of the surgery here, and then click a button. On clicking the button, you get a complete profile. Okay, so it's very easy. So if I'm sitting with the family and I want to explain to the family what is the risk of this patient having a serious complication, I say, the risk of the patient having a serious complication is 44% here. Okay, but average risk of any patient who had all the other parameters for any other surgery would just be 12%. So this is almost 4 times more. Okay, so it gives you Complications like pneumonia, urinary tract infection. If you look at this with fracture neck of femur patients with multiple comorbidities, you'll find, especially in the Western population, that this is a very important thing. Discharge to a nursing or a rehab facility. This patient has a 97% chance of going to a nursing home after the surgery. But I think it's very important that patients understand this choice, because some patients would not want to have that kind of dependency later on in life. So a discussion always helps. Now, do we wait for surgery? Do we optimize? There's a lot of time, I used to say when previously we used to wait and saying that this patient is not stable, I don't think so, we should be doing this surgery. There's a time I've been guilty of that, where you just find an ST depression or a Q wave and say, oh no, cardiology referral. Please don't do that. Please don't. And the only reason I say that is that if you look at this graph, up to 24 hours, there's no harm. Okay? Up to 36 to 48 hours, you can see the mortality curve here, yeah? The 30-day mortality rises massively. And hence, it is very important. These patients are operated within 48 hours. We have a sequence for 36 hours, which means the government incentivizes the NHS for getting patients operated within 36 hours. And we also have a payment attached to that. If we follow what they call as a best practice tariff, and we do everything like a fascia, like a block, sending them to ITU if they require, operate within 36 hours, we are paid better. But I think it's an incentive to us to do the best practice rather than make more money. Post-operative cognitive dysfunction. I mean, this word was unknown 20 years ago. Now, actually, all of us talk about this. Now, what is post-operative cognitive dysfunction? We got to first understand that post-operative cognitive dysfunction is a comorbidity. Okay? It has its own problems. Now, all of us remember when we used to go for, we've heard people say, oh, my grandma went for this surgery and she was never the same person again. Or my relative had this operation and I don't know what's happened, they don't remember. And it can be quite devastating for some patients. Like, I think at the recent WHATS presentation, I heard someone give an example of how she had anesthetized an accountant and that patient could not count properly in the next few months, and that can be such a devastating blow for a patient who's probably come in for a hip replacement or a knee replacement, has general anesthetic, and then has this kind of problem. It's associated with death, increased length of stay, poor functional outcome of delirium, institutionalization, and refractures. Now, there has been some changes with this post-operative cognitive dysfunction nomenclature in the last year or so. There's a new proposed nomenclature now that it's going to be called as perioperative neurocognitive disorder. It's going to be classified as minor or major, and a minor or what we call as post-operative cognitive dysfunction would have a maximum tenure of 12 months. So if you have an anesthetic and someone has what we describe as post-operative cognitive dysfunction and it lasts for more than 12 months, then we won't be blamed for that. So it is going to be assumed that this patient has a long-term neurocognitive impairment which probably appeared while you were giving the anesthetic or just before you were giving the anesthetic. So how do we prevent that? Well, fast-track surgery, get them operated fast, monitoring depth of anesthesia, adequate management of their pain, that's what it should be, and continuous intraoperative analgesia. Avoid cancellations. Please avoid cancellations of fracture neck femur. So what I have here is the AAGPI, which is the Anaesthetic Association of Great Britain and Ireland, the safety guideline from there. This is in the management of proximal femoral fractures in 2011. So what are acceptable as cancellations are HB less than 8, a sodium concentration of less than 120, or a potassium concentration of less than 2.8, the higher end of 150 or 6 for potassium, uncontrolled diabetes, correctable cardiac arrhythmia with a ventricular rate of greater than 120, that means if the patient's AF has a heart rate of 100 to 110, you should go ahead with the surgery, chest infection, but with sepsis, okay? Otherwise you can consider an alternative method of anesthetic like spinal anesthetic, and reversible coagulopathy. Okay? Now, what is unacceptable is us not having a plan of having theatre facilities for these patients. Echocardiography. I mean, there used to be a time, everyone wanted to have an echo. Why? Because we want to rule out aortic stenosis. Why? Because we have to give a spinal anesthetic. That's not the thinking anymore. One of the other commonest reasons are anticoagulants. Because patients come, as I said, on DOACs or warfarin, things like that, and we say, oh, something like dabigatran, we have to wait for 48 hours before you give us spinal. But we've just seen that after 36 hours, the mortality increases. So in this group of patients, you cannot have the same guidelines as you have for elective surgery. So I think every hospital actually has to have a certain guideline for managing of these kind of patients when they come on anticoagulants. Now, in my hospital, we have these ones. I mean, it's a very simple thing. So it's like if a patient's on warfarin, if the iron is less than 1.5, then we proceed with the surgery. Otherwise, we give, Periclex, vitamin K, or anything of that sort. If the patient's on DOAC, so when we say on rivaroxaban, dabigatran is the ones we have to wait for 48 hours, we just say, go ahead and give a general anesthetic. Now, in my personal experience, I have given general anesthetic to almost every fracture neck of femur I have anesthetized for the past 9 years as a consultant. There have been occasions where I have to give spinal because of severe respiratory reasons or anything of that sort. I don't think so. It makes much of a difference, and you will notice that when I move on to my next few slides, that it really doesn't make a difference.